Hello everyone, welcome to Journal Club. Today I will be presenting a recent study with the title Semaglutide in Adults with Type 1 Diabetes and Obesity. This was published on June 23rd, 2025 in the New England Journal of Medicine Evidence. The study was conducted by Viral Shah and colleagues. Dr. Shah is currently a professor of medicine in the Division of Endocrinology and the director of diabetes clinical research at Indiana University School of Medicine. He's been the principal investigator for many clinical trials of diabetes technologies and therapeutics, with a focus on CGM and AID systems. Some background and rationale. Currently, semaglutide is approved for the management of type 2 diabetes and obesity, but not for persons with type 1 diabetes who are living with similar comorbidities. There is increasing prevalence of obesity in persons with type 1 diabetes. Obesity is associated with greater insulin resistance and a contributing factor to inadequate glycemic control. GLP-1 receptor agonists have the potential to improve glycemia in people with type 1 diabetes along with AID systems by improving postprandial glycemia, reducing insulin requirements, and are also known to have cardiovascular benefits. Prior studies have showed glycemic benefits of GLP-1 receptor agonists in adults with type 1 diabetes, but safety and efficacy have yet to be established. This 26-week randomized trial evaluated the glycemic and weight-lowering efficacy and safety of semaglutide in a dose up to 1 milligram per week subcutaneously as compared with placebo as an adjunct to AID use in adults with type 1 diabetes and obesity. The primary objective of the study was to assess whether semaglutide as adjunctive therapy with AID increases the proportion of participants meeting a composite endpoint, which consisted of achieving a CGM time in range of more than 70%, time below range less than 4%, and a body weight reduction of more than or equal to 5% at 26 weeks. Secondary aims were to compare changes in A1C, CGM metrics such as average glucose and time above range, insulin dose requirements, and safety outcomes such as severe hypoglycemia and DKA. This was a randomized double-blind placebo-controlled trial of 26 weeks duration. The participants were adults with type 1 diabetes and obesity who were already on AID systems. 72 participants were randomized 1-to-1 to semaglutide versus placebo. Semaglutide dosing was up to 1 milligram weekly. The inclusion criteria was adults aged 18 to 65 years who've had type 1 diabetes for at least 1 year, have a BMI of more than or equal to 30, and have been on AID for at least 3 months. Approximate baseline stats of the participants were an average age of 40 years, diabetes duration of 23 years, average A1C of 7.8%, an average BMI of 35, and an average weight of 102 kg. Two-thirds of the participants used Tandem Control IQ AID system. Major exclusion criteria was current or planned pregnancy, use of concomitant glucose-lowering medications, non-approved insulin use in AID systems, and any contraindications for GLP-1 receptor agonist therapy. Semaglutide dosing was done as standard, 0.25 milligram for the first 4 weeks, increasing to 0.5 milligram for 4 weeks, then to 1 milligram for the rest of the 18 weeks. A safety follow-up was done 2 weeks after the end of semaglutide use. It was determined that a sample size of 32 patients per group completing the trial would provide 80% power to detect a difference of 32 percentage points between the two groups in the percentage of patients achieving the composite primary outcome. Assuming a 10% dropout rate after random assignment, a sample size of 36 randomly assigned patients per group was needed. Intention to treat analysis was done for patients who did not complete the trial but had already completed visit 4 at week 8. The primary outcome was reported in the between group difference in the percentage of patients achieving the composite primary outcome. The results showed that 36.1% of the participants in the semaglutide group achieved the primary composite endpoint by 26 weeks, achieving a time in range of more than 70%, time below range less than 4%, and weight loss of more than or equal to 5%, while 0% of the participants in the placebo group met the endpoint. The results were statistically significant with a p-value of less than 0.001 and an odds ratio of 7.8. 50% of the participants in the semaglutide group achieved an A1C of less than 7% at 26 weeks versus 22% in placebo. 38.9% in the semaglutide group achieved a time in range of more than 70% at 26 weeks versus 19% in placebo. 75% in the semaglutide group achieved weight loss of more than 5% at 26 weeks versus 8% in placebo. A reduction of 30% in the total daily dose of insulin from baseline was noted in the semaglutide group. I've attempted to convert the results into graphical representation. The top left graph shows the percentage of time spent in range. An increase in time in range of at least 11% was noted in the semaglutide group over 26 weeks versus a 2% increase in placebo. The top right graph shows the time spent below range. The time spent below range was less than 4% in the semaglutide group and was consistently lower than the placebo group. The bottom graph shows the change in A1C. There was a reduction in A1C by 0.7% in the semaglutide group versus 0.4% in placebo. An average weight loss of 9.2 kg was observed at 26 weeks in the semaglutide group versus 0.4 kg in placebo. A BMI of less than 30 was achieved by 41.7% of the participants in the semaglutide group at 26 weeks versus 5.6% in placebo. The total daily dose of insulin reduced by 22.3 units in the semaglutide group, which included a reduction in bolus insulin by 12.5 units per day and basal insulin by 9.8 units per day. Improvement in daytime glycemia was more prominent. Semaglutide-induced reduction in insulin dose was speculated to be due to mechanisms beyond weight loss, such as insulin secretion from residual functioning beta cells or improvement in insulin resistance. The most common adverse events were gastrointestinal. There were 2 discontinuations in the semaglutide group and 3 in placebo. Severe hypoglycemia occurred in 2 participants in each group. In the semaglutide group, 1 hypoglycemic event was reported after the completion of the trial at 13 days after stopping semaglutide. The second event occurred in a participant between week 4 and 8 at 0.5 milligram dose. The patient's sensor was not working and their AID was in manual mode. They took 2 manual boluses for high sugars. A few hours later, they were unconscious and ceased and fully recovered after glucagon and oral glucose. No DKA cases were reported. Some strengths of the study were that it was a randomized double-blind placebo-controlled trial, it had a relevant composite outcome, and showed consistent improvements across multiple outcomes. Some limitations were the small sample size, short duration, and limited generalizability for the population that uses MDI. In conclusion, semaglutide and GLP-1 receptor agonists are a promising adjunctive therapy for type 1 diabetes with obesity. They have the potential to improve glycemia without increasing the risk of hypoglycemia. They reduce insulin needs, aid weight loss, and provide cardiovascular risk reduction. They're currently off-label and larger trials are needed before guideline adoption. As such, coverage barriers remain an obstacle. Today, we see a number of patients at BC Diabetes that are successfully using off-label GLP-1 receptor agonists as adjunctive therapy in type 1 diabetes and obesity. Thank you, everyone.
That's a great paper, Fatima. Thank you. It's been one of my hobby horses for a while, and we've, as you all know, on bcdiabetes.ca/handouts, we've got a paper on using GLP-1s in type 1. I have a couple of comments. Why, you know, Dale, you're the tandem expert, but you know, why was the glycemic control not better in the control group? Secondly, 2 severe lows in each arm, that's pretty high in 6 months. Our rate of severe lows is about half a person per 100 patient years. In other words, our rate of severe lows at this clinic is 1/8 of the rate seen in this clinical trial. Anyway, those are my comments. I'd love to hear more, and
Maybe I'll chime in. It's a great point. Why was control not better in the control groups amongst Omnipod 5, Medtronic, and TSIM with Control IQ? And I think that sort of just speaks to, I think that's still reality. AID systems uh, generally definitely help, but it's also what you do with those AID systems and in terms of the support and the follow up and the frequency of follow up. And I think that what that clinic in Indiana was experiencing is probably not all that different than what free living AID users in the general world experience. I think this is super helpful because I think it does lend on this study was super helpful because it was a randomized control trial published in a very reputable journal. And I think it supports what I think a lot of clinics around the world are already doing. So I think it is helpful to have that support. Yeah, but to Tom's point about why the control group didn't have better control, I think it just speaks to what you do with the AID systems. We're not yet at the point of set it and forget it and just let people be. I think there is some tweaking and adjusting that needs to be happening, and so speaks to the benefit of what we do, why we do what we do every day in clinic. But thanks for choosing it, Fatima. It's a good one.
I do have a question backing up on that same question which Tom just said. Um, on page 2 of this journal, it does say improvement in glycemia with AID systems was largely attributed to the dramatic improvement in overnight glycemia. So why didn't the AID system address the overnight hyperglycemia? And why are they saying that the improvement? Are they saying that the improvement was because of the semaglutide? And doesn't the adjustment, can't you do the adjustments to address the high hyperglycemia, which is overnight? Why would they make a very blatant statement as that? I don't get it.
If Ali were here, Ali did a really nice slide looking at all of our looping experience and found that the biggest improvements in time in range with AID are overnight. Like that's the one that's most sensitive to basal rate, Marla, which is the simplest setting.
Yeah, but then they said that the marked improvement here with this trial was because of the overnight. They were able to make improvement dramatically because of the high sugars at night. Was that attributed to the fact that they were changed the set weren't can't you do the settings changes on the AID system, or is it because of the semaglutide?
I think it's getting back to Dale's point that nobody is adjusting the settings. So
Yeah.
you throw people on Tandem, you hope for the best, and the ones who get Ozempic do a whole lot better. Simply, you know, Marla, overnight is the simplest one because you don't have food interfering with the calculations and the pump calculations.
Yeah. Okay. So my only take is maybe those on AID, we have to take a look at the settings that are set for overnight in order to bring all that down and maybe improve it. That's all my thing.
Yes, and I guess it'd be a great question for the authors of the study, but my hunch is that adding a GLP-1 agonist on top of an AID system simply magnifies the benefits of the AID system. Yeah, so I think it's not surprising. I think it's not surprising because the AID system maximizes the benefit of the overnight control to the limitations of how you've got it set up, and then having a GLP-1 added in just simply magnifies that benefit, I think.
And I do also have a follow-up questions because we have a lot of type 1s in clinical trials, and we do start them up on GLP after they've gone over a little bit on whatever study drug that they're on. Why? And I've had some occasions that endos that are type 1 patients in research study who have different endos and not our own endos in the clinic are hesitant to start them off on GLPs. Why would type other endos be hesitant to start type 1s on GLPs? That's one question. Um, what was the other question? I forgot. But anyway, just addressing that for now.
Well, I have a comment on that one for sure. endocrinologists as a general rule are not risk takers. Endocrinologists as a general rule are like type A, follow the rules people. And I think just that's the personality that goes into endocrinology. And so the fact that GLP-1s are off label, I think is the main reasons why endocrinologists are hesitant to do it, because of the lack of randomized clinical control trials. Well, I shouldn't say lack of, I say the lack of acceptance by regulatory agencies that it's an okay thing to do. That being said, definitely as we see more and more people, and I appreciate maybe a biased group, but when we look at referrals from endocrinologists for looping to our clinic, the number of patients, I don't know, Tom, what you would say, but the number of patients who I see with type 1 diabetes who are coming in on GLP-1 agonists with type 1 diabetes has definitely been climbing, I think, just over the last 12 months. So I think it is shifting. But even that being said, tend to be a pretty conservative group.
And other than, I just remembered my other, it's not a question, it's a comment, is that we're going to be doing trials now.
Marla, let's let the other group, everybody else chime in before you continue.
Make that last comment. Okay.
Maybe nobody else has got anything. Okay, finish it up, Marla.
Okay, the only thing is that we're doing it, we're approached to do a study with type 1s with a dual agonist, so GLP and GIP. So I'm just letting you know that apparently it looks like not just GLP is going to be in the future. It looks like GLP is not enough to address the glycemic control in type 1, but they're already doing GLP, GIPs, and maybe in the future, even triple agonists.
I'll add another comment. I think it'll also be really helpful for us to get more studies in people with type 1 diabetes using GLP-1 or other agents who do not have a BMI greater than 30. It's unfortunate commentary on our public health status that the population living with type 1 diabetes with BMI over 30 is certainly increasing. But I also want to make sure that the non-weight benefits of these therapies are not, like, I want to make sure that everybody gets access to it, because I think it's not just for weight management. So it'll be helpful to have those studies too.
Thank you, Dale. Looking at our last DPD snapshot, we have 4,442 type 1s, and of those, 365 are on a GLP-1, so almost 10%. I'm often prescribing Mounjaro as a pay out of your pocket add-on in type 1s for anybody with a high total daily dose, anybody who wants to lose weight, really anybody, I guess. Rachel and I just started a looper whose total dose is 160 or something, Rachel. BMI is 42. And I labeled her as a dual diagnosis. So she's in DPD, she stays as a type 1, but in the free text section below it, I today added the notation that I think she has type 2 diabetes on top of her type 1 based on her BMI and total daily dose. And that's how we justify putting in a special authority to pharmacare. Dale, have you been doing anything like that, or your comments?
I perhaps not quite as creatively. I think for patients who are interested and are willing to be cash payers, that's kind of the way I would have gone, just having the patient pay for it. But on that note, I'm also talking about with patients who it might be appropriate, the fact that Ozempic patent is going to be running out, and that we know 5 manufacturers are now have applications to Health Canada. So in 2026, semaglutide will hopefully get a whole lot cheaper for those cash payers. But I think continuing to sort of beat the drum about these kinds of research studies that Fatima, you just presented about for new indications would be really, really helpful from a population level. But I'm still getting people to pay.
A lot of private insurance companies are covering these drugs for weight as well, is the other thing. So if someone's BMI is like over 35 generally, definitely over 40, a lot of their private insurance will cover it.
Yeah, good point, Tristan. But that will be for Wegovy, the obesity label for semaglutide.
Mm-hmm.
To that
I have
point, Dale, Duncan and I tried to put someone with a BMI of 30, and it was turned down by PBC, which sets the bar at 35.
Tom, just a very quick question. Do you see the same effects of the plateauing effect of a GLP on type 1 as compared to that with type 2?
I don't know. It sounds like a really good study idea.
And highlights the fact that I don't think we have longer term studies in type 1 diabetes using GLP-1 agonists like we do in the type 2 world to formally answer that question. Like this study was only 26 weeks to that point. But I don't think there's any reason to suspect that it wouldn't be any different, that it's probably a 3-month plateau at a steady, like a one dose. You'll likely see the effect at 3 months. I don't think there's reason to think it would be different in type 1, but I don't think we've got the studies.
And the other question is, did you ever start anybody on tirzepatide for type 1 on a dual agonist? And why would you choose a dual agonist over Ozempic? Is it because of the BMI?
I'll answer that. It's because of price. It's cheaper, Marla.
Oh.
If you use our hack, maybe you don't know about our Mounjaro hack, but if you prescribe the 15 milligram pen and use 1/6 the dose, which is 10 clicks, it's about $2.60 a day, and it's probably a bit like 1 milligram of Ozempic. There's never been a strict head-to-head at that level, but it's pretty effective.
And also, if you're doing it under the not under the guise, that's shifty, but if you're doing it for weight management with an increased BMI and you prescribe it under the label Zepbound, then they do become eligible for the myzepbound.ca as a cash payer, so they get a discount too. That we've done.
Dale, have we tried with private insurers? Have any private insurers covered a type 1 on Zepbound?
My memory's a little shaky, but I know we have definitely done Zepbound paperwork for someone with type 1, and we just never bring up the type 1. Like, it's just don't put it, it's not written anywhere on the sheet of paper, so it's solely for weight. I can't comment on whether or not it's been successful. I would assume it has been.
Everybody, so Zepbound is the obesity indication of tirzepatide. So it's like, as Zepbound is to Mounjaro, so is Wegovy to Ozempic.
Yeah, I put one in for my patient, I think a few weeks back. So we're just waiting on that to see for Zepbound.
For type 1?
Yeah.
But you just don't say the word type 1.
Yeah, the indication is for obesity.
Yeah.
Yeah.
And good plans, and I think more and more plans are going to be covering. Wegovy is pretty widely covered, but Zepbound will be more and more covered over time, I think, by private insurers, just the way that Mounjaro was picked up.
And maybe just a perspective shift. It's important for us to all be aware that GLP-1 agonists for weight management are not contraindicated in type 1 diabetes. Like, quite the opposite. Like, so we're going for weight, and it's totally appropriate. You fill out the form. It's good.
I have a question about this study for newly diagnosed type 1 diabetes for preservation of the beta cell function. Is it coming soon, or?
Has everybody click on the hand on the link in the chat? It's, these documents are created historically by me, but now Dale is also creating them. And we are open to you guys having suggestions and things we add. There is a paragraph on addressing the preservation of beta cells. It's quite a big topic. There is, you'll see the Dr. Paresh Dandona. This guy was the lead author of another article in the New England Journal showing dramatic remission in people given Ozempic open label in newly diagnosed type 1s. And so I've talked to him, and he actually had an RCT in newly diagnosed, which was kiboshed by Donald Trump's cutbacks to the to the FDA and the NIH. So these studies are definitely being considered and planned.
We had a patient a few days ago that we started him on a very low dose of Mounjaro. He was recently diagnosed with type 1 diabetes. BMI was normal. So I will update you later.
We've got a few of those.
Yeah.
Dale, have you how many people have you started in that indication?
I honestly don't think I've started anybody newly diagnosed for beta cell preservation. I think all of my starts have all been in the context of weight management, insulin resistance. But if there is a growing number of them, it might be interesting, I don't know, to pull that together and kind of look at their numbers and see how they've progressed.
Yeah.
But if you do a prescription on newly diagnosed type 1 for Mounjaro, I thought it wasn't indicated. Do you just put it on and as for weight? Well, how do you make out the prescription, Mariam? How do you go about this?
You just write the prescription and they show up with their credit card. That's it. You can prescribe anything.
Yeah, they won't ask, I think.
And you would explain to the person why you're doing it with
Yeah.
the normal BMI, so I mean, people are aware.
Yeah.
It's amazing. It's interesting too, Fatima. If you look at your if you look at some of the spreadsheets, some of the tables that you have, that the population of those that are educated and making an income much higher are actually those that are actually involved in the trial. If I look at those numbers, I saw
That's true.
because who would start on Mounjaro newly diagnosed? I mean, usually they're not even unless they have some funding from their own parents or something, right? But where was that page, Fatima? That's interesting. I noted it.
It's page 5.
Reem and Rachel, I was interested to see how they did their power calculation. And I think looking to predicting, what proportion of people will make, will exceed a time in range of 70 might be a clever way of managing the power calculations. Because, Rachel, was it we did the power calculation in the Omnipod 5 versus Loop and got a huge number?
It was like 160, something like that.
Yeah, let's redo it.
Yeah.
And Reem as well. Let's redo it.
Sure.
Just hypothesizing we will find a difference. Like their power calculation was for a 30% difference, which was still huge.
Mm.
Like I think we could easily argue for, we could argue for 10 points. What do you think, Dale? 10 points is a bit generous, isn't it? But
I think 10% change. Yeah, well, that's good.
No, let's say a 10% difference in the proportion with a time in range greater than 70. Yeah, that 10% is pretty low, isn't it?
I don't know. On first pass, that sounds quite reasonable, actually.
Okay, good. Rachel and Reem, please do it. Give us the answer.
Okay.
Okay.
Great journal club, Fatima.
Doctor, I have a question.
Yeah.
Is there a study that correlates the amount in the blood and the serum of fasting C peptides and fasting blood glucose with the use of GLP-1 agonist in type 1 diabetes? I mean, thinking in the mechanism of action of the medication and also the reservoir of how functional alive are the beta cells in the pancreas. If there is a study like that.
Short answer is yes. And I think that speaks to the whole beta cell preservation studies that have been done. So yes, there is, and more coming.
But Jose, in today's study, these people all had type 1 for a while, and their C-peptides would not have been measured in this study. It's assumed that they're low, but of course they're not zero.
Fatima, great journal club. Thank you everyone for coming out.